things a little bit and go to the tachy phase of things, of supraventricular arrhythmias. Talk about ventricular arrhythmias after Dr. Zimmerman's anticoagulation talk. Now, sick people have these arrhythmias as well. This is what I showed earlier. We have to make a correct diagnosis first, fix what's wrong with the patient that's precipitating these things, and get rid of that stuff, and make sure that we're treating the patient and not the arrhythmia. This is perhaps even more important in these tachyarrhythmias, that the alarms go off and everything, and everybody gets all excited, and we need to keep some perspective about things. Now, there's this category called supraventricular tachycardia. This had been called PAT, paroxysmal atrial tachycardia. That was an older term. I don't think many in this room are even familiar with that nowadays. That's good, because it's just not a very useful term. It's a family of disorders, not diseases, but disorders. They have similar features and are characterized by relatively regular and rapid, usually narrow QRS complex tachycardias. You may or may not be able to see the P wave that's causing the QRSs. Quite often these are catecholamine related. Almost all of these disorders that can occur spontaneously get gasoline poured on them when you get some catecholamines going. Sometimes intracardiac lines will cause these. We'll see some examples of that. The significance of these range from almost nothing. It's something they've had all along in their life, and it's just not much of an interruption during their ICU stay or their hospital stay. Or it may be very important, causing a tremendous decrease in cardiac output, and you really have to deal with this very significantly. Acute therapy, adenosine is not the fix to all things, but it's pretty close, and it's quick. Even if it's not the right thing to give, you're not saddled with a lot of baggage for more than just a few seconds if it causes any problems. Longer term therapy, for many of these, ablation is an answer. For some, medication is an answer. For some, nothing's necessary. There are different types. There's sinus tachycardia that anybody can have. It's very common, obviously, in the ICU setting. It always has a cause. We'll see this a little bit later. It's not just something by itself in almost all cases. Atrial tachycardias can be focal, just a focus firing away that occurs in a structurally normal heart. Reentrant tachycardias occur almost uniformly in the presence of somebody's done something before. A surgeon's been in there, a catheter ablationist has been in there before, radiation has been on the heart before. There's some scarring that's occurred. It's rarely seen in individuals without prior instrumentation of some sort. AV nodal reentry, the most common type of supraventricular tachycardia of these categories here. There's two major types we'll talk about. AV reentry as opposed to AV nodal reentry. This is all within the AV nodal. It's a perinodal region. This is using both atria and ventricles in a big circuit, using an accessory pathway between the two. Junctional tachycardia, not real common in free-living people, sometimes more common in the post-op, post-cardiac surgery, especially valve surgery crowd. And while atrial flutter and fibrillation are technically supraventricular tachyarrhythmias, we don't usually talk about them in the same breath as these guys up here. That's always befuddled me somewhat, although they are topics, large enough topics on their own. We'll come to them subsequently here. Sinus tach, very common in critically ill patients due to the underlying cause that is bothering them, and the elevated adrenergic tone, withdrawal of vagal tone. These are normal appearing P waves, positive in the inferior leads and in lead 1, and usually isoelectric or positive, negative in V1. There is a characteristic rate that can be due to sinus tachycardia. So in a 75-year-old who's going 200 beats a minute, that is not sinus tachycardia. It cannot be sinus tach. It's an atrial tach or something else, but it's not sinus tach. So you don't need to look as to whether they have blood loss or fever, anemia, that's what pulmonary embolus, pneumothorax, that kind of stuff. But these are always the causes you look for with sinus tach. Why is the patient's heart rate going up? Is there something physiologically driving this? You need to find that and correct it, not just throw beta blockers at these people. So find what the cause is, and so on and so forth. Ischemia won't cause this, but it can cause ischemia in somebody who's got severe coronary disease and compromised coronary circulation, and they're going fast because of their catechols. You see this occasionally when we're doing it to people with norepinephrine or epinephrine. Long-term therapy is not necessary in these people. Treat the underlying cause. Atrial tachycardia is a heterogeneous group of disorders that have a non-sinus P wave. Sometimes they look a lot like sinus because they're coming from the crista terminalis, but not the sinus node. One clue in when they occur spontaneously is that they are driven by themselves. They're not typically driven by catecholamines like sinus tach is. So if you're in sinus tach, the PR is normal or even short. In atrial tach, without the catecholamines driving the sinus node, there's no reason for the AV node to shorten its AV conduction. So the PR is sometimes a little bit longer in those cases. And of course, you may have non-to-one AV conduction. That's a good clue that it's not sinus tach. Again, we were talking about the focal tachycardias in the structurally normal heart. Catecholamines can fuel these episodes quite reliably. They may not have too much outside of the ICU setting where they're all catecholed up, or we're giving them some exogenously. Reentrant tachycardias rely on a prior atrial scar of some sort for these causes of which I spoke earlier. These may have not much clinical significance, but if you're getting on some catecholamines, they can complicate the situation because now you've got a little bit of a compromise in cardiac output from the rapid rate. Beta blockers, calcium channel blockers, rarely is cardioversion necessary for these actors, but occasionally if the patient's really compromised. Long-term therapy, call your local electrophysiologist if it's really that much of a problem for the patient. Here's an individual with a 32-year-old man who's had palpitations on and off for 3 years, and he's coming along here with clearly a lot of P waves along the way. Sometimes he conducts, all along the way here, he's conducting 2-to-1. So atrial tachycardia with 2-to-1 conduction, kind of an unusual P wave inverted in the inferior leads. This happened to be a source from the musculature of his coronary sinus, the vein that's behind the left atrium. Here's somebody with atrial tachycardia with 2-to-1 conduction, and the P wave is upright in the inferior leads, but it's, if you can see it very well, it's not very easily seen in lead 1, but it's negative in lead AVL, so it's coming from the left side. So it's a left atrial origin. This is a fellow who's had a left lung transplant because of pulmonary fibrosis, and he had a tachycardia from off over there, kind of an interesting case we did not too long ago. AV nodal reentry, very common disorder. People can have this on the outside of the hospital, so they can have it on the inside of the hospital as well. There's this thing called dual pathway physiology in the AV node. There's a thing called the fast pathway. That means there must be something called the slow pathway as well. That has a longer conduction time. Most people who have dual pathways are hanging out in their fast pathway with AV conduction. Normal PR interval, nothing unusual. But if something comes along that causes block in the fast pathway, like a premature atrial complex, it can go down the slow pathway and then come back up the fast pathway, and you're off and running. These have inverted P waves in the inferior leads because the AV node is relatively low in the atrial septum. The typical form, the most common, goes down the slow pathway, up the fast, so the P wave is stuck inside the QRS. You may not see any P wave with this. It may look like just junctional tachycardia with no visible P waves. There are a couple of atypical forms here. There's the atypical so-called, where you're going just kind of the reverse of this, anterograde fast, retrograde slow, so it's an inverted P wave just in front of the QRS. And then there's the atypically atypical, slow, where you're using 2 slow pathways, and this is a P wave kind of between QRS complexes. This is the physiology of how an episode gets started. Dual pathways, we're conducting down the fast pathway normally, slow pathway, still conducting down it, but it by virtue of the fast pathway being fast, it wins, so you don't ever see evidence of slow pathway during sinus rhythm. Comes along a premature complex, the fast pathway has a longer refractory period. It can conduct that rapidly, so it blocks. It's kind of like the tortoise and the hare, so the hare blocks here and goes down with the tortoise. It goes down and causes a QRS complex with a longer PR interval. That's great if it were only that, but it turns back and goes up the fast pathway, giving rise to a P wave then with this pseudo S wave just peeking out the end of the QRS complex. And then if the slow pathway, if all the elements are still able to conduct, then it goes spinning around and around, spitting off impulses in both directions to atrium and ventricles. This is one of only a couple of intracardiac recordings I'm going to show you. So bear with me here. This is a patient who has, one person who was lucky enough to have 3 forms of AV nodal reentry. And just to concentrate up here on these A's in the high rate atrial recording. These A's are with the QRS, they're before the QRS, and they're between the QRS complexes. So the circuit goes down slow, up fast, up slow, or up and down different slow pathways here. This was a very vexing case from about 20 years ago or so. Leaving that disorder and going to a slightly less common one, atrioventricular bypass tracts. We know this is Wolff-Parkinson-White syndrome. If there's pre-excitation, not everybody who has a pathway like this has pre-excitation. They can be concealed. Retrograde-only conduction. The Wolff-Parkinson-White is our very familiar short PR interval and delta wave disturbing the beginning of the QRS. Looks like a left bundle branch block in some cases. Looks just funny in other cases. It may simulate an inferior infarction if you've got a pre-excitation pathway connection on the inferior wall, so all the voltage is coming upwards at the beginning of the QRS complex. Looks like a Q wave. These pathways usually conduct retrogradely also. Not all pathways conduct anterogradely, but almost all conduct retrogradely. That you can have a couple of different circuits with this. The so-called orthodromic or normal direction tachycardia goes down the AV node like it normally would, goes through the ventricles, comes to this pathway it can conduct, and then goes around in a big circuit. It can reverse that direction with antidromic tachycardia, much less common. Or the pathway can just be there as a means of conduction to the ventricle during atrial fibrillation, atrial flutter, atrial tachycardia, and not really have much to do with the ongoing arrhythmia itself. So this is how it works. We got sinus node up here, AV node, and this pathway off on the left side, very common location for it, left lateral. And during sinus rhythm, we go down the normal conduction system, but because there's no delay inherent in AV conduction over the accessory pathway, the bypass tract, it rockets down there. There's no AV nodal delay, so you start the QRS very early. The PR interval is typically shortened somewhat. And because some of the ventricle is activated over the pathway, some of it over the normal conduction system, each complex during sinus rhythm is a fusion of some sort. Typically, the beginning of the QRS is a little bit slurred, the end is a little bit faster, because now it's governed by the His-Purkinje system over there. So sinus rhythm comes along. Here's a PAC, and we now do not conduct down the accessory pathway like we didn't conduct down the fast pathway with AV nodal reentry. It nonetheless conducts down the normal conduction system with a little bit of a longer PR. And if the pathway is ready to conduct again, when it comes all the way back around here, we get a retrograde P wave that's after the QRS complex, and then it keeps going around in a big circuit. Now, here are a couple of examples of sinus rhythm of that sort of thing here. Here is a right-sided pathway activating the right ventricle first, left ventricle last, looks like the left bundle branch block. And because the pathway is pretty close to the sinus node, very short PR interval, sometimes the P wave is not even completed by the time the QRS complex starts. Contrast that with a left lateral pathway. The left ventricle is activated first, therefore the right ventricle last, therefore it looks like right bundle branch block in most regards. Big, tall R waves in the right precordial leads here, a rightwards axis here. Looks very peculiar, like a lateral infarct, a posterolateral infarct, but it's actually just pre-excitation. And then this is orthodromic SVT, recognized by typically narrow QRS complexes, a P wave that follows the QRS complex just after it here. And I don't expect that this is just for interest. I don't expect you to see that, go by your monitor and the patient is going fast. Oh, it looks like orthodromic SVT with a left lateral pathway. Probably, most electrophysiologists are not going to catch that off a monitor strip. These can go really fast sometimes, even with a normal QRS complex, especially in younger individuals. They may respond to carotid sinus pressure. They will almost always respond to adenosine or verapamil. Certainly adenosine given correctly and large enough amounts will knock off most of these people. These are very amenable, 99+% successful with catheter ablation, but of course you're not going to do that in your typical setting. This is an individual with a pre-excited tachycardia. These are very wide QRS complexes. It is almost impossible to distinguish these from ventricular tachycardia just on an ECG. Fast VT will usually not have retrograde conduction. We do have P waves after each of these guys. You have to look for them sometimes, look for them where you can see them. And this is not always this antidromic tachycardia. This is an example of antidromic tachycardia. But you can have atrial tach or AV nodal reentry. Any other type of supraventricular arrhythmia that's conducted down this pathway will make it look crazy like this. And of course, we treat the underlying disorder and usually the pathway along with it. Pre-excited tachycardias are not common, and this antidromic tachycardia down the pathway up the AV node seen in only about 5% of people with Wolff-Parkinson-White. So not a very common thing, so not very common in your setting as well. This could happen. This is atrial fibrillation conducted down an accessory pathway. Young persons in automobile accidents who have a WPW, they can have lines in their heart, tickle their atrium, and go into atrial fibrillation. Up to 30% of people with WPW can have this disorder. It can be a very bad actor. If they conduct very, very rapidly, they can go into ventricular fibrillation. We just had a few of those already this year. And of course, that's a pretty bad outcome. We had, I think, 3 last month in our institution. Now, in recognizing which of these you're dealing with, the P holds the key in diagnosis. There are 3 different characterizations of the P wave that I teach my guys. First of all, you look for P waves where you can see P waves. And you don't look off and lead V3 or V4 to see what does a P wave look like. It doesn't tell you much information, number one. Plus, you don't see a very good P wave in sinus rhythm, so why should you see one during these other rhythm disturbances? They're best seen in the inferior leads. Don't forget about AVR, which is sort of an analog of V1, not always. I asked my guys to think about it in 3 ways. What's the AV ratio? How many A's do you have for the V's? If it's greater than 1 A to the V, you're not dealing with one of these AV nodal reentry or that type of things. That's almost always 1-to-1. And you're dealing with atrial flutter, atrial tachycardia, maybe atrial fibrillation. You don't usually see discrete things that you can call P waves at atrial fib. They're fakes if you do. If a 1-to-1 AV ratio could be anything except atrial fibrillation. I asked them to look also at the timing of atrial activation. If you don't see any visible P wave, you're probably probably is one there, just not seeing it very well. And it could be most likely AV nodal reentry, perhaps junctional tachycardia. If the P wave deforms the end of the QRS complex, so-called pseudo-S wave, and leads V1, and in the inferior leads, it's typically AV nodal reentry or junctional tachycardia. It's not a common disorder, but it can certainly look like that. A short RP interval, that's from the beginning of the QRS to the beginning of the P wave that you can see, most typically AV re-entry using a bypass tract that you make the QRS, and as soon as you come up the accessory pathway, you start making a P wave, so it's a short RP interval. AV nodal reentry can do this, especially in older individuals, not so common. And then this long RP interval, we'll see examples of this, where you have a very long period between the beginning of the QRS and the next P. In fact, it's a short PR interval. Atrial tachs can do this, some types of AV nodal reentry, the atypicals, and AV reentry rarely with a very slowly conducting pathway. I see one of those every couple of years, so you're not going to see that very often probably. Then I asked them to look at the morphology of the P wave. So we talked about the AV ratio, the number of P waves per QRS, the timing of the P wave relative to QRS complexes, and then the morphology of the P wave. Is it positive in the inferior leads, in which case it's likely sinus tachycardia or an atrial tachycardia coming from high in the atria, or negative in the inferior leads, which is a more common situation. It could be AV nodal reentry, atrioventricular reentry, or some atrial tachycardias. This is a kind of a decision tree. You won't see this book very often. This is a text on clinical cardiac electrophysiology that many of your colleagues may have, but I hope they have it anyway, as I'm one of the primary authors on it. But it's not going to be in most folks' libraries or on your shelf, but it talks about, you'll have it in your handout here, so it talks about all these things here that we have discussed previously, and in the interest of time, we'll go on. This is a diagram also in your materials with a normal lead 2 for reference of the positive P wave and what it looks like here, and then no visible P wave because the P wave is in the midst of the QRS complex. If you think about it, a normal QRS complex is about 80 milliseconds, 100 milliseconds wide. A normal P wave is about 80 milliseconds wide itself. That's 40 milliseconds from right atrium to septum, 40 milliseconds from septum to left atrium. If you're coming up the center, activating both atria simultaneously, you get that same 40 milliseconds for each atrium. So it's easy to hide a 40 millisecond P wave in an 80 or 100 millisecond QRS complex, and that's why we don't see any visible P wave in situations like this. P wave deforming the end of the QRS with AV nodal reentry, most typically. Then the P wave moves out a little bit further. That's a bypass tract completely forming the QRS complex before coming up to the atria over the mitral or tricuspid annulus. And then this long RP tachycardia here. A variety of things can cause that sort of business. There are a couple of ways of distinguishing these things diagnostico-therapeutically, that is with adenosine effect. What happens when you give adenosine? Well, there's some that are responsive, some that are resistant. AV nodal reentry, AV reentry, and many atrial tachycardias will fall by the wayside with adenosine given properly. Now, you have to give it properly. You have to give it a push, big vein, big flush, because red cells, of course, metabolize this stuff. And for many of these disorders, it has to go all the way through the lungs and get into the arterial circulation before it'll have an effect on the AV node, certainly. Adenosine-resistant tachycardias, some atrial tachycardias will not respond to this. Atrial flutter, you'll get AV block, be able to see the flutter waves better, but it won't terminate. Certainly atrial fibrillation won't respond to adenosine aside from slowing the ventricular response. Choice of acute therapy depends on the context. How ill is the patient? How important is it to get rid of this thing for the patient to be better? Rarely will we find with these disorders an acute precipitant that you get rid of that and all the problems are gone. If they're hemodynamically stable, adenosine and the doses shown here, verapamil, metoprolol sometimes, esmolol, I don't find particularly useful, but for the acute termination, these others are better. If they're hemodynamically compromised, you can still give the adenosine. It's quicker than cardioversion. You can almost always get hold of it and give it quickly and get your answer. Sedation obviously is very important with synchronized cardioversion. Usually low energy is okay with these folks, don't need high energy, and just burn the patient and stuff like that. But sedation is very, very important. You don't make any friends with unsedated cardioversion. Frequent bursts of SVT, cardioversion is irrelevant with that because they're stopping on their own. All a cardioversion can do is stop the episode acutely. So metoprolol or diltiazem is the best choice for that sort of thing. Atrial flutter. Now we're switching gears entirely here. We have considered it separate from SVT, although it really is a supraventricular arrhythmia. It has these so-called sawtooth flutter waves, especially in the inferior leads, most typically with 2 to 1 or 4 to 1, not 3 or 5 to 1 or 7 to 1. It's usually 2 or 4. That's just how the math works out with the refractory periods and rates in the AV node. Common settings, right atrial enlargement, COPD exacerbation, pneumonias, etc., or somebody who just has it anyway on their own. It is very difficult to control the ventricular response. Not so hard with AF in some atrial fibrillation in many cases. You can kind of dial in your rate with the proper medicines. But with atrial flutter, we're sometimes left with choices between 2 to 1 or abrupt 4 to 1. So you go from 150 down to 75, just whoomp, and not very much in between. Ibutylide can terminate these. Amiodarone can sometimes terminate these. DC cardioversion, it's fine. Ablation is a really, really straightforward procedure in most of these cases. Almost 100% success with that. Easily recognized on the ECG with these sawtoothed flutter waves here in the inferior leads. I didn't point those guys out. These sawtooth flutter waves here, also seen in V1 here. Usually the rate's around 150. It can be a little bit more than that, the ventricular response, because the atrial rate is usually around 300. Almost any size patient, almost any age patient, very close to 300. I've seen them with some atrial disease very much slower than that, but that's an unusual situation. And here's sawtoothy flutter waves of left atrial reentry in somebody who's had a prior atrial fibrillation ablation. Again, but we can see that most of the interval between P waves is occupied by atrial activity. So there's something going on all the time. Here's an electroanatomic map that we make during our EP studies of rotation around the tricuspid annulus. The larger the atrium, the larger the tricuspid annulus, and the slower the rate, just because the path length is larger. Now, atrial fibrillation, a very common disorder. Lots of challenges for us in the ICU setting. There's obviously the stroke risk and the poor hemodynamics. These are two very different manifestations. Acute therapy has to address both of these things. Quite often, and especially in older individuals, only rate control and anticoagulation are necessary, and we're often constrained in our choice of medicines by what other disorders is going on. So we have this undulating baseline, irregular RR response, quite readily recognized here. Now, the pathophysiology of this has undergone some revision in the last several years. We just didn't know what it was until about 20 years ago, and it became clear that pulmonary vein triggering got things going. There's probably also some contribution from the atrium itself, a so-called substrate that requires a trigger, but then it gets going, and these rotors in the atrium, I have a great interest in that myself with some research we're doing. In some patients, sustained pulmonary vein firing is it. That's all you need. You isolate the veins electrically in the EP lab, and the veins are still fibrillating away, and the rest of the atrium is just being very nice and quiet. Medications will prolong refractoriness and inability, provide the inability to maintain fibrillation, maybe not get it started either. And then a lot of long-term therapies are necessary as well in some cases. This is looking at the back of the left atrium here with the 4 pulmonary veins, left veins, right veins, superior and inferior vena cava. And you might have a focus that's firing in there. You might have ganglionated plexi that get people irritated. You might have a focus that fires and gets a rotor going in the atrium that keeps things going. And then you can come along with pulmonary vein isolation with all that. This is a little bit faster than it actually takes to do these procedures. Come along with these ablation things and cut through many of these, either interrupt transmission from the pulmonary vein, cut through a rotor, eliminate a ganglionated plexus, and so on by diverse mechanisms. This is one of the only other intracardiac recordings I'm going to show you. Here we have a sinus beat here, left atrial activation, and these very sharp things are signals in the pulmonary veins. They get an episode going here along the way. A little flurry. It looks like just a couple of PACs, but there's actually atrial fibrillation on the inside, and then it goes back to sinus rhythm. After we've electrically isolated the veins, those signals are no longer there. That patient should not have fibrillation again. Nice story. Doesn't always work out that way. Controlling rate in these individuals in the acute setting can be difficult. You can use diltiazem, you can use esmolol, you can use amiodarone, but all of these have baggage. They don't work, especially the amiodarone doesn't work immediately. These guys cause hypotension. Sometimes a nice soup is to have these guys, diltiazem or esmolol, and a little bit of phenylephrine, either as intermittent boluses or as an infusion to support resistance that these guys are diminishing. Oral metoprolol, oral diltiazem, just what it takes, whatever is appropriate here. Now, rhythm control versus rate control, this is usually not your main dilemma in the ICU. You're just trying to get them through that stay here. Intravenous amiodarone or ibutylite can be used. Remember, importantly, that the risk of torsade increases with a longer QT interval. You need to make sure the potassium and magnesium are fine beforehand, and that risk of torsade lasts for up to 6 hours after you're done with your infusion. So this is not an emergency room drug. It's an ICU drug or a hospitalized patient drug because you have to monitor them afterwards. External cardioversion works best, in our experience, with antero-posterior pads or slightly right of peristernal, and left posterior, the atria are right through that vector there. You get your best results with that. 50 joules, 25 joules will sometimes work. You can increase if necessary. Remember that there's a distinction between a failed cardioversion, you just can never get them back into sinus rhythm. I find that extremely rare. Or somebody who gets to sinus rhythm and they immediately refibrillate. That cardioversion worked. So you don't need higher energy in that individual. You need a drug to keep them out of fibrillation. Here is a synchronized shock here. We're coming along with synchronization marks on the monitor here. We deliver a shock. And then there are no synchronization marks afterwards. This is important because your device always devolves to asynchronous after a shock is delivered. This is in case it's ventricular fibrillation. You don't sync for that. So you always have to resync, and there have been some pretty bad situations when that's not done. Anticoagulation, I hope everyone's familiar with the CHADS and CHADS VASC scoring systems. They're there for you. We had this kind of voodoo 48-hour rule. If the AF episode lasts less than 48 hours, we can go ahead and cardiovert without anticoagulation. That's usually pretty good, but it's not perfect. So when in doubt, thin it out. Try to do some anticoagulation for people who have been in atrial fibrillation. You're contemplating doing cardioversion. Now, atrial flutter fibrillation. This is kind of a goofy term here. The ECG may look like flutter, but the flutter wave is not identical in all. If you look for a few seconds across V1, it changes. Flutter doesn't do that. Fibrillation does. Or the ECG looks like flutter, but very irregular RR response. That's a little bit unusual for flutter. Does it matter? No, it doesn't matter. You're going to anticoagulate, you're going to rate control, you're going to rhythm control, however you do it one way or another. It doesn't make any difference whether it's flutter or fibrillation. So here is this stuff that looks like flutter over here, but then over here it doesn't look like flutter again. So this is just fibrillation. it doesn't matter so much. All right, so a couple of questions here to finish up. A 90-year-old woman with pneumonia has a heart rate of 150 a minute, as you see here. She's not had this before, and what's the diagnosis? Sinus tach, atrial flutter with 2-to-1 conduction, atrial tachycardia with 1-to-1 conduction, or AV nodal reentry. Okay, that would be a good choice ordinarily. Let's go back and look at the, as 150 is a very characteristic rate for that sort of thing. Now, this is not sinus tachycardia because she's 90, and 90 plus 150 is 240. That's too fast for sinus tach. Could it be AV nodal reentry? She's never had this before. Teenagers, 20-year-olds, people don't get to 90 before having AV nodal reentry, so that's wrong. And so the question is whether it's flutter. Do we see a second flutter wave here? And I think that we only see a single P wave here in the inferior leads, and it doesn't look very sawtoothy. It looks a little bit positive in in lead 2 here, piled on top of the T wave. So I think we only have one P wave per here. I'm not going to give you too much trouble for trying atrial flutter with 2-to-1, but it is atrial tach with 1-to-1 conduction in this situation. Okay, this is my last question here. A 56-year-old man with liver failure begins to have this rhythm. His blood pressure ranges from 70 to 100, and what's your best course of action? Sedation with cardioversion, metoprolol, amiodarone, or adenosine? Okay, cardioversion is not an answer here because this rhythm is stopping on its own each time. We get our slide back here, this way, this way. This stops here and then it restarts and stops. So if you cardiovert this, what's going to happen is it's going to restart on you. So you need to do something to stop this rhythm, and quite often this is going to be due to just focal automaticity in the atrium. You could give amiodarone. Adenosine is no better than cardioversion. It just stops an acute episode and then it starts right back up after the adenosine's gone. So metoprolol is a better choice there. I'm not going to fault you too much for the amiodarone. So in summary, we got very common arrhythmias in the ICU setting. They may be transient, they may be a long-term problem for the individual. Treat any underlying causes, and sometimes you'll need help from one of us. Thank you, sir.